डॉक्टर साहब आप भी सर काइंडली अपने शेयर करके दिखा दें.
Sir, we are live on Facebook.
चलें. Bismillahirrahmanirrahim. Ladies and gentlemen, welcome back on our weekly program of EOS and ERCP webinar series. Today we have a very important topic, and that is not something which is unusual. We come across with this challenge, this problem almost on daily basis. It's a case of acute cholecystitis or distended gallbladder when the surgeon is not ready to operate, the anesthetist is not ready to give the anesthesia. In this situation, what exactly is to be done? We have a panel of expert people. We have the expert people like Dr. Amar Server, interventional radiologist, evergreen and uh, ever most informed person, Professor Dr. Khalid Hassan. And then we have top of the top surgeons, Professor Farooq Afzal, who happens to be the president of Society of Surgeons as well. And he is a renowned name in the bariatric surgery. So I shall take a lead. I shall set the things. I shall take the honor to begin the things, and I shall just set the stage so that the coming speakers are going to take further um, views on things that they want to share. So we all know now. Can you see my slide? All right. So this is the topic, the Distended Gall Bladder Management in surgically unfit patient. Although we know that even if a person is surgically unfit, still the surgeon can do something. And for on that account, that's the reason that I included Professor Farooq Afzal, and I requested him pretty late after realizing that surgeons are always the last person to take. You must have seen this cartoon. This was published in a recent Lancet editorial. And you can see that on one side, we have the interventional radiologist. On the other side, it is us, the gastroenterologist, where we are putting the tube into the gallbladder. So on this side, it is the ERCP or US side, and on this side, it's the interventional radiologist side. And uh, what are the patients who are surgically unfit? We must realize that in um, um, 2013, there was a consensus statement given by the Tokyo group on acute cholecystitis. And they had given, first of all, the Tokyo um, grading 2013, and then they revised it in 2018. And they had divided acute cholecystitis risk into various grades, grade 1, grade 2, grade 3. In the following slide, I'm going to show you that. And grade 3 is the one which is associated with the significant risk factors that we usually come across. And then the patients suffering from chronic liver disease with significant thrombocytopenia, we know that in our society, in our country, we have a heavy burden of chronic liver disease with cirrhosis of liver. And in the face of cirrhosis of liver, even if the treatment has been given, still there are a number of patients who have got cytopenias, not giving us the clear-cut indication, clear-cut playground to do the interventions. And in that account, again, we are limited in terms of the in terms of the intervention that we can do in these patients. And then there are certain patients who got the anatomical abnormalities in the patient. This is the classification that I was talking about. That we have grade 1, where it's a simple, straightforward affair. But this is the one, grade 3, where most of the time we are challenged that people have cardiovascular dysfunction, they have hypertension requiring treatment with dopamine or other anatropic support, then they have got neurological dysfunction with impaired level of consciousness, the GCS scores down, respiratory dysfunction, although in this era, while we are facing COVID, we always worry about COVID, but then people who are suffering from sepsis, people who are suffering from septicemia, they have impaired oxygenation of the blood, and renal dysfunction is something which comes in part and parcel with any patient who's got significant sepsis, especially in the hepatobiliary tree, and hepatic dysfunction. And hepatic dysfunction not because of the chronic liver disease, but hepatic dysfunction because the patient liver function is down because of the sepsis in the nearby area. Hematological dysfunction where the platelet count is less than 100,000, but to be honest, it is less than 500,000 where we are really worried about in a given patient. And then the other grading, grade 2, grade 1, where the patients are suffering from significant inflammation. So I shall start off with certain cases, and these are real cases that are challenging. And this first case, I remember it. This is a memory of my life. Uh, a case where a patient was on ventilator, a young female, 45 years old. Uh, she had pain and fever for the past 7 days, and by the time she came to us in the hospital, she was already toxic, hypertensive, tachypneic, and had to be ventilated. And it appeared as if we don't do any kind of intervention, patient is likely to die. I counseled the patient's husband, who was intelligent and understanding, despite the negative counseling that I did in that patient and the negative odds that the patient had, like WBC count 32,000, platelet 35,000, INR 2.2. Uh, Her husband agreed to the intervention. And this was the bedside ultrasound that we did. And this is the CT scan images of the patient. You can see that the gallbladder is distended and the intrahepatic biliary channels are distended in this patient. Uh, we did the ERCP in this patient. There was distended gallbladder. Possibly there was a stone in the neck of the gallbladder. And similarly, that stone was pressing on the main line of the CVD, leading to the dilatation of the intrahepatic biliary channels. A stent was placed in the main duct, and another double pectoral stent was placed between the gallbladder and the duodenal lumen. Another case, 75-year-old male who had recent acute coronary syndrome and had undergone uh, angiography and stenting. And on the following day, he developed acute biliary colic with cholangitis, and he rapidly went into shock. Patient was already in ACS, so combination of cardiac event at the same time, cholangitis, septic shock, and then out of that, there was a significant renal dysfunction as well. Bedside ultrasound was done. We showed distended gallbladder with the dilated intrahepatic biliary channels, and there was a fluid around gallbladder. An MRCP showed dilated intrahepatic biliary channels and a negative shadow at the hilum of the liver. So another ERCP showing roughly a similar picture, but in this case, the stone was impacted without um, um, it was impacted at the neck of the gallbladder with the dilatation of the intrahepatic biliary channels, and there was a significant distension of the gallbladder. So, a uh, stent in the uh, and then we tried to take out this stent, take out the stone from the cystic duct, but then it was difficult. So ultimately, we ended up putting up a stent between the gallbladder and the duodenum. Case 3, a patient which was referred from a peripheral hospital, acute cholecystitis with empyema was a diagnosis, and ultrasound guided drain was placed with a consequential biliary peritonitis and sepsis and septic shock. And the reason was that few of the holes were outside the gallbladder. So what we did was that there was a stricture in the gallbladder as well. So did was that we put in stents in the common bile duct, and then we put in the stents in the between the gallbladder and the duodenum while taking out the drain which was there. And patient recovered within 24 to 48 hours with good antibiotic. Case number 4, another patient, 55-year-old female with gallbladder empyema and obstructive jaundice. She was septic with platelet count 20,000, INR 2.8, and creatinine is 2.5. In this uh, case a little more complicated. We had a stricture lower down in the CVD with involvement of the cystic duct and then dilatation of the proximal biliary channels. The guide was placed into the main biliary channels, dilatation was done, and then the guide was placed into the gallbladder, and a stent was placed between the gallbladder and the duodenum, and similarly, stent was placed in the proximal biliary channels and the duodenum, a straight stent. So double pigtail between the gallbladder and the duodenum, and a straight stent between the uh, proximal biliary channels and the duodenal lumen. So this is usually the thing that I do. So, what are the predictors of success in the endoscopic mediated gallbladder drainage? First of all, the people who have a dilated CVD and have got CVD stones, they're more likely to have a successful drainage of the gallbladder. If there are stones in the cystic duct, they're more likely to respond. And then the position of the cystic duct, especially if it is at the standard right upper side. I'm going to show you the cartoon very soon. If the position is there, there are more chances that we are going to be successful in draining the duct in successful. And what are the tricks for successful cannulation of cystic duct? Important thing is that we should try cannulating cystic duct without sphincterotomy. And then a wire which has been bent, maybe an old wire. I prefer using an old wire, but then elbow wires, if available in the department, that can do the trick. Swing tip cannula is very good. If the swing tip cannula is not available, then with a standard sphincterotome, it is best that we should try to bore it and rotating in different directions. And by the management of the guide wire, we can tip the guide wire into the right direction. If possible, if introductory ultrasound probe is available in the department, yes, that's something which can be of great help. Similarly, spyglass, if available in the department, that can be used for the cannulation of the cystic duct. Guide wire rotation with the rotator in the hands of the technician. Again, that is something that we can use in directing the guide wire towards the cystic duct. Distal balloon inflation, which has been recently shown by one of our colleague and highlighted in the PhD forum, uh, putting up a balloon in the proximal channels, inflating it, and with another wire, sending it from the ampulla up into towards the channels and trying to negotiate towards the cystic duct. That's another technique. And two wire technique that I use quite often, that putting in a wire up and then on parallel to that, with the help of sphincterotome, I try to direct the wire towards the cystic duct, and most of the time I'm successful. What are the risks associated with endoscopic mediated transpapillary gallbladder drainage? It's not without risk. It's not like draining the CVD. It's not like draining the pancreatic duct. There is some more as compared to the other drainages. And the cystic duct perforation can occur, especially if we are not gentle with the management of the tip of the guide wire. If we are using the stiff portion of the wire as an anchor, a gallbladder which is inflamed can perforate, can tear. Pancreatitis is a risk, but the magnitude of the risk is just as much as in the other ERCP. And bleeding is definitely a risk, especially because in gallbladder drainage, most of the time the patients are suffering from um, concomitant diseases. People are suffering from either acute coronary syndrome, and they're elderly and they're taking antiplatelet drugs. And it is not possible for us to withhold our management for 3 to 5 days, which is usually the recommendable kind of thing. Or the people who are suffering from chronic liver disease and have got the emptying of the gallbladder, the otherwise interventions are not possible, again because the low platelet count and coagulopathy which is ongoing in these patients, that puts these patients at a higher risk. But still, the risk of bleeding is less as compared to the risk of bleeding with the other interventions like EOS guided or with the IR mediated guided. So, so risks are there, but risks are have to be explained to the patient's family, and there with the pros and cons. So, what kind of drainage can we offer to these patients? If you're doing transpapillary stenting, we can do double pigtail, which I usually do most of the time. People have put in straight stent. People have used these self-expanding metal stents as well. Although I don't have a personal experience in the straight or self-expanding metal stent in these situations, I have always used double pigtail stents. Transpapillary and nasopapillary drainage are usually used. 7 French is the one which I use most of the time, but people have used 10 French stents as well. But I prefer using 7 French because they're easy to maneuver, they're easy to manage, and as since they are less stiff, so the chances of damage to the cystic duct or chances of damage to the inflamed gallbladder are relatively less. There's been a couple of very elegant studies which have been published in the past couple of years. One of these studies which has been published in the journal PON by Kim on the endoscopic transpapillary gallbladder drainage for the management of acute calculous cholecystitis in patients who are unfit for urgent cholecystectomy. And the results are quite interesting, that out of 171, they were able to do it in 155 patients. So the success rate is pretty good. And then in the cases where they were able to um, uh, do the successful drainage, Um, Ultimately, cholecystectomy was done in 60 patients. People died of pneumonia in just one case, and conservative management was possible in other 5 patients. And uh, conversion was not in too many patients. Uh, the ones in whom the drainage was failed in 16 patients, percutaneous drainage and then cholecystectomy, and all this was possible in those patients. So the technical success was in as many as 90.6% patients. Intention treat success was in 90% patients. Early adverse events, not too many, but obviously the two main complications, pancreatitis and post-EST bleeding, were the main things. And late adverse events, stent migration, stent occlusion, persistent cholangitis, recurrence of the infection. These were the main late adverse events. But generally, in these patients, once the patient's condition settles, in 2 to 3 weeks' time, the surgeons take over and they do um, uh, the necessary ultimate step as soon as the patient's condition improves. In the same study, the logistic regression analysis of factors was successful. Transpapillary gallbladder tendency showed that if we combine all these factors together, the most important are in terms of beneficial they are, age and CVD, and rest of the things are not really as important. And this is the overall comparison, the overall chart, which shows that the endoscopic transpapillary gallbladder drainage with stenting for acute cholecystitis patients in high-risk surgical patients is a good option in these patients, although there's been a significant number of morbidities, significant number of mortalities in these patients. This is a very interesting flow chart which has been published in just recently by World Society of Emergency Surgery in terms of acute cholecystitis diagnosis and in people who have got high risk, and taking it in this algorithm. One thing is very clear. Um, which are the patients who will be needing endoscopic uh, transpapillary drainage, how to go about, and the recommendations are very clear that in those patients who have um, high risk factors, they should be taken to the gallbladder drainage, may it be the PT percutaneous, may it be the endoscopic, and if the success is there, they can be discharged for to be brought back to the elective surgery. But otherwise, rescue surgery is required, for which we have Professor Farooq Afzal with us. And with this, I thank you for your patient listening, and I hand it over to Dr. Khalid Hassan for his EOS guided biliary drainage talk. Khalid sir?
Thank you, Gaspai. I'm gonna just share my screen right now. Okay, so I will talk about the mainly EUS guided part of the gallbladder drainage, and okay. So with regard to the endoscopic drainage, one of the options, as Dr. Gyas already mentioned about that, is really via ERCP. And the other option of percutaneous, Dr. Amar is going to talk about that later. But basically, endoscopic drainage, we are talking about the patients who are unfit for surgery, which are high risk for any reason. Could it be a systemic disease? Could it be a malignancy? And the patients who went in the ICU. So for any reasons who are unfit for surgery, the options really include either percutaneous or endoscopic. And with regard to endoscopic, EUS component is placing a stent into the gallbladder transluminally. There are multiple sorts of stents. It could be a plastic stent, it could be a metal covered stent, it could be a lumen opposing metal stent. All these have been tried, and actually there have been a meta-analysis of different studies showing the efficacy and showing the risk associated with all these type of stents. So sometimes there's a question what type of a stent we should place in these cases. So you can use any of these stents, plastic or metal, but there is a little bit high risk of bile leakage, especially in cases where you use the plastic stent. Risk of adverse events could be up to 20% or so, but you can use any of those stents. So gallbladder drainage via EUS guided, it's not really something new. It's been tried for the last 15 years or so. There have been multiple case reports, as you can see from here, and different type of stents has been tried with multitude of success. But majority of the time, it is quite safe with regard to adverse events. But you can see there are different type of risks associated with it. So you have to keep that in mind. And there have to be expertise available to proceed with this kind of procedure. There have been total, I believe, 6 randomized trials, especially comparing EUS guided with the percutaneous drainage. One of the first one was published in 2022. Here you can see percutaneous drainage and EUS gallbladder drainage. They are total close to 60 patients. And in these, with regard to success, technical as well as clinical, with regard to complication rate, conversion to open cholecystectomy, there's really not much difference. And one of the things which really made some difference was the pain post procedure, especially within 24 hours. And that is self-explanatory. Percutaneous, you got to go through the skin, and that they are going to have some pain. But endoscopic, that was less pain in those patients. And then now one of the most recent ones where they compared EUS guided with percutaneous. As the technology evolved, as we got better with the clinical skills or procedure skills with this EUS guided biliary drainage, we have gotten better with the results and success as well. And if you look at here, you can see that with regard to adverse events, it seems like EUS guided drainage may be better than percutaneous drainage. But as far as the technical clinical success is concerned, you can see there's no much difference. So really, it depends on expertise available, and EUS guided expertise may not be as universally available as compared to the percutaneous. So you really have to depend on what you have, what are the resources available there. Patient selection for gallbladder drainage, either percutaneous or EUS guided. Obviously, we're talking about the patients which are unsuitable for surgery. But one thing, just make sure before you even attempt that any of these, make sure there's no necrosis or perforation of the gallbladder. And if there is any concern about that, obviously we can get a CT scan to make sure that. Other patients which could benefit from that, a lot of patients have a percutaneous drain for cholecystostomy. However, taking care of the percutaneous drain is not easy. They are not happy with that. That is one of the indication we can convert percutaneous to internal drainage. And also other indication would be these patients who have a failed ERCP or EUS guided biliary drainage for any reason. Usually it's a malignancy. In those cases, just to drain the liver or the biliary system, you can consider EUS guided gallbladder drainage as well, or percutaneous. But obviously, these patients need to have a patent cystic duct. And sometimes over a passage of time, the tumor takes over that area as well. So there is a chance of failure in those. And so you have to be careful with the patient selection. This is one of the videos. This is one of the older videos in which patient already had a percutaneous drain placed. And they just wanted it to be converted into endoscopic or internal drainage, transluminal drainage. You can see that there is a percutaneous drain already in there. Actually, that is sometimes helpful because the gallbladder would be decompressed. And what you can do is you can put saline or sterile water through that area and extend the gallbladder for easy EUS guided success. This one, after puncturing the gallbladder with the needle and then putting the wire and then dilating the tract with the cannula, and then the tract was dilated with the small 4-millimeter balloon, and then this is fully covered metal stent, long one. It's not a lumen opposing metal stent. After placing the stent in these, if I use this type of a stent, then I want to stabilize that stent with the double pigtail stent. That just helps in prevention of migration of the stent. So this is one of those cases. You can see there was a metal stent and double pigtail stent then placed through that. What are the steps? As I mentioned earlier about the plastic and fully covered metal stent and lumen opposing metal stents as well. There are different type of lumen opposing metal stents available. There's Korean, there's Nagi, there's we have access to Axios stent, which is by Boston Scientific. Previously, we used to have this cold Axios, and now we have a hot Axios. So this is these are the steps really with the cold Axios stent, where you don't use a cautery. You see a distended gallbladder, you have access, put a wire in there, have multiple loops in there. Then you can use different accessories to make that stoma a little bit bigger. You can use a cystotome. Obviously, that comes with, you use heat with that. You can use cannula, and then you dilate a little bit, and then you can put a lumen opposing metal stent over the wire. You can see at the end. However, this is the next slide is pretty much same from pictures from the same case, but this can tell you how the hot Axios is going to work. In hot Axios, majority of the time, some people still use wire, but if I have to do, I like to have a free hand, because that expedites the procedure and give you more control of the stent. So in hot Axios, lumen opposing metal stents, you just find the right area to puncture the gallbladder. Just go in with a cautery and stent, release the internal dumbbell, and then you can release the external dumbbell. So if you have access to a hot Axios stent, then you don't need the needle or the wire. You can go straight with that, just like draining a big pseudocyst. So gallbladder, which is a hot gallbladder, cholecystitis, usually it's going to be big, and you can access that without the need of wire. One thing is, like, you can, when you if you have done these, or when you do this, access to the gallbladder endoscopically either is going to be really close to the pyloric channel or from the duodenal bulb. So if it, one thing is, be careful in a sense, like your scope should not be unstable. It's not, and that's for any endoscopic procedure, and especially US guided these drainages. Scope should be in a comfortable position. You should be in a comfortable position. And so just some little bit movement is not gonna make you fall back or lose your position. For these stents, either you choose the duodenal bulb, and if it happens to be close to the pylorus try to stay a couple of centimeters away from the pylorus, because you don't want the second dumbbell, which is going to be in the stomach, blocking the pylorus itself and food getting stuck in there. Many times we end up doing a duodenal bulb, and that is more helpful in that regard. So this is one of the article which I published a long time ago on EUS guided gallbladder drainage. Basically, bottom line was it's useful for in patients with large amount of ascites, surgically unfit fit patients. Main advantage, lower pain scores, less discomfort. It is comparable and safe to percutaneous drainage, less risk of infection because there's nothing hanging out of the body, no tubes there. Also, it has been proven on now in multiple randomized trials that there are fewer reinterventions, and patients have a better quality of life. So with this, I will end my session, and I think next is Dr. Amar, and he's going to talk about percutaneous drainage.
Yema sir?
Yep, just one second. So, can everybody see my slides?
Yes.
Okay, excellent. So first of all, thank you all for inviting me to speak. I'm going to talk about distended gallbladder management in the surgical unfit patient, the role of interventional radiology. And I want to go over just very quickly the guidelines that all of you have mentioned. And so these are the Tokyo guidelines from 2018. And it's really in grade 2 or grade 3 that we're thinking about non-surgical interventions. However, there are a number of different guidelines available on how to decide about surgical versus non-surgical options. The American Association of Trauma Surgeons also has an acute cholecystitis grade that is based off of description, imaging, as well as operative findings in determining whether to go ahead with a completion cholecystectomy or to take the patient to the OR versus trying endoscopic or IR related intervention. And there are some studies which talk about differences in prediction of mortality for the AAST guidelines versus the Tokyo guidelines, complication rates, or the need for cholecystectomy. So these curves, which are basically area under the curve, ROC curves, are showing that the ability of the AAST guidelines is a little bit better than the Tokyo guidelines in predicting mortality, complication, as well as the eventual need for cholecystectomy for patients who present. At the end of the day, I think the decision to which patient to take to the operating room versus do a bedside or an endoscopic procedure is really based off of a local center's expertise and availability of different key specialties. The classification system that we use the most at our center is really the American Society of Anesthesiologists Physical Status Classification System. And we do this because it's robust, it's been around for a very long period of time, and it's relatively easy to use. And I think anybody who's giving moderate sedation or deep sedation, which is true for most endoscopists, interventional radiologists, I think this is a good system to know about which patient to take to the OR versus not. Typically, anybody with a ASA 4 or 5 score will go for bedside or endoscopic drainage. ASA 3 is a little bit of dealer's choice, so I think it's up in the air depending on the center, whether the patient goes to surgery, IR, or endoscopy. And ASA 1 and 2 almost always go to surgery. This is a system that we use quite frequently at our hospital. So obviously, if somebody's come in with acute calculus cholecystitis, they'll have hospital admission and supportive care. I think this is a key factor to decide. And, you know, I wish there was a diagnostic radiology component to it, because I think the decision making is really going to be based off of what does the gallbladder look like on the ultrasound. Because if there's evidence of gallbladder gangrene, if there's evidence of gallbladder perforation, if there's a dropped stone in there, if there's emphysematous cholecystitis, these are factors that probably will favor one approach over the other. And so if none of these are present, then obviously we're going towards determination of surgical risk. And within determination of surgical risk, the low risk patients typically will end towards either a relatively delayed cholecystectomy or an emergency cholecystectomy. However, once you come to the high risk score, which is the ASA 3 to 5, which means that the patient's critically ill or septic, then we start to think about, is the patient improving on the antibiotics or not? And if they're improving on antibiotics and there's a certain subset of patients that will work for, and you don't need any type of intervention, I think then you can reassess the surgical risk after the cholecystitis has resolved. In other cases, if the antibiotics are not really working or the patient is in septic shock, then we start to think about percutaneous or endoscopic drainage, and then obviously the cholecystectomy afterwards. I will point out that in certain cases who remain to be high risk even after clinical resolution, and these are patients who are not good candidates for general anesthesia, then we want to start to think about non-surgical stone dissolution, extraction, or they may still benefit from some IR and endoscopic therapies. So the question for, we're talking non-surgical patients. So let's say your center's decided, the primary team has decided that this is a non-surgical patient. So who are you going to call? So is it going to be ERCP, EUS, or IR? And so I think the first thing to think about is the patient's tolerability for deep sedation. So typically, in good hands, percutaneous cholecystostomy or percutaneous interventions can be provided with, let's say, one drug, maybe an IV narcotic, and some local lidocaine. I think the type of cholecystitis that is present is important. I think the location of the gallbladder is important. You know, most gallbladders, unfortunately, don't read the textbook, and especially in patients with cirrhosis or misshapen livers, you may have difficulty in getting a good percutaneous approach under ultrasound. I think determining the ability to transfer the patient, whether you need the procedure to be done at the bedside versus transfer the patient down to the endoscopy suite or the ERCP suite is a key question. Although I'm sure some of these procedures could potentially be done bedside in the right situation. I think, as Dr. Qiyas mentioned, I think one key factor is the ability to cannulate the cystic duct from the transpapillary approach, usually possible, but sometimes can be difficult. And then obviously the cost and available expertise for EUS, which is an advanced procedure. And so I think the ability to have the stents available and everything is a key deciding factor on what is going to happen. So having given that overall overview of kind of how we approach these patients in our institution, I thought I would give a very brief and introduction to the percutaneous procedures available from an interventional radiology perspective. And so the simple and the oldest is the percutaneous cholecystostomy. It's been around for forever. There are two approaches. One is a transhepatic approach, which means that you take a piece of the liver or a bite of the liver on your way into the gallbladder. And the other one is a transperitoneal approach in which you're not going through the gallbladder at all. There are advantages and disadvantages to all of these. In general, I prefer the intracostral approach with an approach through the some part of the liver. And the reason for that is because the drain is much more stable because you're passing through a solid organ. And so that's kind of holding onto the drain, and the risk of leakage and free spillage of bile into the peritoneal cavity is reduced. So that's my general feeling. However, as you see here, there are some disadvantages. So first of all, if you're going over the ribs, or if you're cutting, if you're going under the rib, that's bad technique because you're going to nick an intracostal vessel on your way in and may have a bleed. But if you're going over the rib, there's some patients will have pain around the rib, and it can be quite uncomfortable, especially with breathing. Depending on the liver and how high up in the chest it is, there's also the risk of nicking the pleura on the way in, and that's something to carefully look for as you're doing these procedures under ultrasound guidance. The peritoneal approach is a subcostal approach, typically, and it avoids the issues with the pleura, and it avoids the issues of site pain related to the rib. However, this is a little bit free floating. And so if patient's taking deep breaths or it's a really obese patient, the possibility for the pigtail to slip out of the fundus of the gallbladder is possible. There are a variety of interventions that interventional radiologists do from a transcholecystic approach, including into the cystic duct and the biliary system. And so if you're planning to do that, eventually a transperitoneal approach gives you a better angle towards the cystic duct, typically, unless of course there's a low insertion. And so this is kind of what it looks like on CT. It depends on the window that you get. Over here, there's a really nice window to go transhepatic. And so in this patient, I would probably pick to go transhepatic. And you can see that here, needle kind of going in really nicely into the gallbladder. You can watch it all the way in. However, here, the gallbladder is so nicely up against the abdominal wall that you can get a very nice transperitoneal approach. And it would be very difficult to try to place this from a transhepatic approach coming through this rib space over here. And so that's why this is probably the easier approach. The other thing for interventionalists to be aware of is the colon. And, you know, sick patient in the ICU, somehow they're always the worst patients to scan. These are typically also obese patients, at least in the American population. And so you have to be careful about where the colon is sitting in relation to your intervention, because it has happened that in the rush to do a cholecystostomy or with a poor window, that you're going really close to the colon and may cause some damage in that area. In general, though, this is a study that compared the short and long-term outcomes of transhepatic versus transperitoneal placement, and they found really no difference in the complication rates. And I think the key factor here is the comfort of the operator. And so the operator should really be aware of how he's been trained, what type of procedure he has the most experience with. But this is also a good slide to show some of the issues with percutaneous gallbladder drainage catheters, which includes site pain, skin infection. Biloma formation is extremely rare. I haven't really seen that in my practice. Cholangitis is possible, but again, you have something that's open to drainage. And these are the common ones. So first of all, catheter-related issues such as catheter leakage, the catheter getting dislodged, it got pulled out, it fell out. Those are always common issues with percutaneous drainage catheters. Abscess formation is rare. I think bleeding, one may ask the question, like you're going through a solid organ, and let's say somebody is in septic shock and they have deranged coagulation parameters or abnormal coagulation parameters. What are the chances that you're going to cause a lot of bleeding? And the answer is that the risk is actually quite low. And the reason for that is because the catheter itself, first of all, you're going so distal or so peripheral in the liver that the size of the blood vessels that you're crossing with good technique is extremely small. And secondly, because the catheter is kind of tamponading the tract that you're passing through, again, the risk of bleeding is typically very small. However, if you're going intracostal and you go below the rib, you could have an intracostal bleed. And sometimes patients, try to keep us humble and honest, and they'll bleed regardless of how good your technique is. So something to be aware of when we're thinking about percutaneous interventions. So finally, I would say this is something that we all know. There's a certain subset of patients in whom after you have achieved a decompression for initial symptoms, there is the challenges of a long-term drain. They're not surgical candidates. They're never going to be surgical candidates. And so now they have a bag attached, let's say every night or a few hours every day to drain out the gallbladder. The drain needs to be changed out every 3 months because the bile can be thick and these drains tend to clog. The drain can get pulled out. There could be leakage around the drain. You're managing the dressing every day. The drain, as I mentioned, could get clogged. So these are some of the challenges of a long-term drain. And so this is one of the reasons, I think, first of all, in my perspective, a natural orifice route for any intervention would be preferred to creating a new access through the skin. But the challenges of a long-term drain is really one of the main reasons why a percutaneous cholecystostomy, while it's a necessity in a really sick patient, is not a very attractive option from a patient perspective. And so with that in mind, in recent years, interventional radiology has been doing a lot of percutaneous interventions to try to aim for a drain-free survival is the term that we like to use. And so percutaneous cholecystolithotomy is a technique in which we basically use our percutaneous access and upsize it using nephrolithotomy catheters and balloons to, let's say, a 24, 26-inch access. And we're able to put in a small scope to basically look at the stones, disintegrate them using lithotripsy, and then get a very nice result in terms of a patent cystic duct and CBD, and then you're able to eventually remove the catheter. And so the aim currently at experienced centers is to really perform percutaneous endoscopic procedures, stone extraction techniques, and try to go towards drain-free survival. This is an example of a patient in whom you probably don't need a scope. And so this is somebody who has numerous small stones. We got a percutaneous access, upsized it to a large sheath, and then using a bunch of forceps and baskets, we're able to clear out these small stones. Now we have a patent cystic duct. Everything's kind of flowing through really nicely, and the drain can eventually be removed. The outcomes and complications for percutaneous cholecystolithotomy are well described. It's been around for better part of 30 years, but only recently have we started to use this more commonly. And so typically you're able to use smaller and smaller scopes as time has gone on. The technical success rate is quite high, up to 100%. Recurrence rate typically is low, although possible. And then the complications are typically small as well. Most of these complications are related to the site of the skin. The typical technique for doing this, just for people, I don't have a slide on this, but is to basically place the cholecystostomy tube, wait about 4 weeks for the tract to mature and epithelialize. And then after that, you basically bring the patient back for another procedure. You put 2 wires in through your existing access, one as a safety wire, the other as a working wire. And then you upsize the tract up to like 20 French or so over the working wire. And then you're able to introduce your endoscope and use the working channel and the other techniques to remove these stones, kind of similar to what you would do if you were doing a ERCP procedure. And so finally, let's say the stones are gone, you've done the percutaneous cystolithotomy, but the gallbladder continues to drain. The cystic duct is patent, the bile keeps coming out this way, and you cap the patient, but the drainage persists. In those cases, one of the percutaneous techniques that we provide is ablation or embolization of the cystic duct, followed by chemical ablation using ethanol or STS for the gallbladder itself. This is also a well-described technique. And again, I think one of the main drawbacks of the percutaneous cholecystostomy tube, the way that is used generally, is the fact that the patient is stuck with a long-term drain. But between cholecystolithotomy, removing the stones, and then chemical ablation along with embolization or ablation of the cystic duct are some techniques that I think are really important to be aware of in order to make sure that the patient has a drain-free survival, which I think is an important thing for quality of life. And so in conclusion, I think percutaneous cholecystostomy is a safe, effective, and cost-effective intervention for decompression of gallbladder in patients unfit for surgery. Percutaneous cholecystolithotomy and gallbladder ablation is a relatively newer technique for stone removal and drain-free survival in patients. But I think it's something to consider for patients who are going to have a drain in long-term, and try to get more of our patients free of their drain as soon as possible. Thank you very much.
Thank you, Amar. Thank you very much. Now, can we have Professor Farooq, sir? Amar, did you stop sharing? Good. For your presentation is going beyond the screen. You need to reduce the size of the window. No, that's better.
Okay, do you see my screen now?
Yes, we can see your screen, please.
All right, thank you very much for the invitation, especially Professor Riaz Nabi Tayyab and the Pakistan Society of Gastroenterology. There is a very important point which I want to highlight is that the acute gallbladder disease is a surgical problem, and the definitive treatment is a cholecystectomy. But I understand these patients are sometimes so sick, either because of their disease or because of their comorbidities or ESS scores, that you need a multidisciplinary approach. And our approach is that we see whether we need an external drainage of the system or whether we need an internal drainage system. So if I need a internal drainage system, that means that the cystic duct is patent. So I will ask my endoscopic colleagues when I think there is an associated cholangitis along with that. And if the patient is very thick and obese, as Amar was mentioning, I will request my interventional radiologist colleagues to intervene and help us. Otherwise, I think especially in our third world setup where these facilities are evolving and not yet universally available, I think surgically placed tube in the gallbladder, especially in those patients who are unfit for surgery, is the standard of care in most of our setup. Okay, so we all know the natural history of acute cholecystitis. 90% of acute cholecystitis is obstructive. And when there is an obstruction of the duct, there is obviously a bacterial inflammation leading to either ischemia or a gangrene, leading to a perforation which is localized, creating an abscess, or a generalized perforation leading to peritonitis and sickness. And we all mentioned the Tokyo guidelines, basically grade 2 and 3 severe cholecystitis that are basically we are discussing here. The standard of care for the grade 1 is a standard lab chole, which can be done after a brief period of antibiotics in such patients. So we remember that as the age increases, so does the risk of or incidence of gallstones. And the problem is with the increasing age, the risk of perforation also increases. Majority of these acute gallbladders can be managed by a conservative treatment like antibiotics. But since these are elderly sick patients, those who have comorbidities, the perforation rates are also very high. More than 40 to 50% of these patients will develop perforation if they are not treated. But operating in such patients in emergencies will lead to a very high mortality. So such patients who have increased risk of perforation because of the disease, but simultaneously operating them, even doing an emergency cholecystectomy has a higher mortality. So we need to think of some bailout procedure. And this cholecystostomy is the best bailout procedure or a bridging procedure to definitive therapy. So what is cholecystostomy? I don't need to define that. You already know that. Now, what factors determine the need for a cholecystostomy? My colleagues basically beautifully illustrated those, but just I want, for the sake of residents who's here, I divide them into 4. These are the patient factors. Most of the Tokyo guidelines basically focus on the disease factors, whereas the Western and the US guidelines, especially the AASD, they focus on comorbidities and the ASS scores, right? So, and then there's the disease factors, grade 2 to 3 grade of Tokyo guidelines of severity of acute gallbladder or anatomy or pathology. Sometimes the pathology creates so much difficulty to establish the critical view of safety that although the patient was fit for anesthesia, but during surgery, we have to do a bailout procedure in the form of cholecystostomy. and that can save the patient from further BDI injury or common bile duct injury or other injuries. And then the third factor is the surgeon factors. Obviously, surgeons who are skilled and experienced they can operate on such sick patient, but those surgeons who are in initial career or initial period of their experience, it is better that they should convert these patients into a cholecystectomy, either laparoscopically or an open one, while they are managing such patients. And one of the advantages why we do this is that it leads to resolution of acute cholecystitis, and it has a lower morbidity, low risk of BDI and mortality, and sometimes it is a definitive treatment in about 25 to 30% of patients with acute gallbladder. So when to consider placing cholecystectomy tube? I remember telling my resident the 4 Ds. Now, what are the 4 Ds? When you want to drain, when you want to decompress, when you want to divert, and when you want a definitive treatment. So high-risk patient in which you want to decompress acutely inflamed gallbladder because you want to prevent a perforation, or you want to drain an infective or a perforated gallbladder, you must think of a cholecystectomy. Then definitive treatment or a bridge to definitive treatment, and then a bailout during a difficult cholecystectomy while you are operating, either or doing an open or a laparoscopic cholecystectomy. And then you can decompress when there is a biliary obstruction or a cholangitis. And sometimes you have to get this for an access and to visualize system, especially we do gastric bypass in which there is no continuity of the system. So if there's a gallbladder available, can be used for imaging as compared to the ERCP which we use. And then in the trauma situation, especially the trauma, the grade 5 and 6 pancreatic or duodenal injuries, this cholecystectomy has a great role in diversion. So what are the advantages of a surgical cholecystectomy as compared to percutaneous or endoscopic? Well, the biggest ones are you can place a wide bore Foley's catheter, which is very cheap, right? And you can also remove the stones without using these modern gadgets, which what Dr. Amar was mentioning, and you can aspirate the thick pus and debris simultaneously. There are less chances of peritube leakage and collection, and the fixation of the tube is much better surgically. And at the same time, if you have to replace a blocked tube, you can replace it. And my most important point is that we do not have endoscopic and interventional radiologists available all the time. This is the cheapest of the alternative which is available for drainage of the gallbladder. Now, there are 2 types of techniques: open, with or without ultrasound guidance, or during a bailout, like during an open or a laparoscopic cholecystectomy. The only contraindication is, which is relative one, is a coagulopathy. So just a diagram, I know that most of you are not a surgical resident, but just an open cholecystectomy using under a local anesthesia. The first thing you identify is the gallbladder. As Amar was mentioning, sometimes the location of the gallbladder is very difficult, so you can take the help of an ultrasound, or you can enlarge the incision and just palpate for the gallbladder, aspirate it with the needle, send it for culture and centrifugally increase the hole, put a trocar in, aspirate the gallbladder, decompress the gallbladder, remove the stones, and then pass a pulse string and place a wide bore Foley's catheter and anchor it with the peritoneum or the inferior abdominal wall. The other way is to do a laparoscopic one. So you are in the middle of a cholecystectomy and you thought that the anatomy is very difficult. The critical view of safety was difficult to achieve. So here's the time that you abandon the procedure very early on before damaging the bile duct. And this is it's a great bailout procedure. The other bailout procedures are partial cholecystectomy and fenestrated cholecystectomy, but I would recommend strongly for my younger colleagues that if you are in trouble, please use this. Then after you have placed a tube, what to do? Well, we usually remove it after 2 to 4 or 6 weeks with a contrast study showing a patent cystic duct and no stone in the CBD. And secondly, 70% of such patients can have a definitive procedure, which is the interval laparoscopic cholecystectomy. With a very few of them would need a conversion to open, and 20 to 30% would not need a cholecystectomy. They probably will get better, or they will not be having any symptoms later on. This is our personal observation as well. These patients very small subset would not need any cholecystectomy later on, and they can live with this. This is a cholangiogram for, you see how beautifully it can tell you the status of the cystic duct as well as the common bile duct. There is an interesting data from US. They compared this, they did a propensity analysis of those who had the cholecystostomy tube and those who did not. And they showed that, and this was presented in SAGES, and then they showed that those with cholecystostomy tube had a lesser incidence of survival. My criticism is that those who needed a cholecystostomy had a greater incidence of sickness from other diseases. Acute acalculous cholecystitis is the one which is majority of time present in critically sick patients. And those patients, they either, the majority of them, they don't die because of their gallbladder disease. They die of their associated sickness or illnesses, maybe MI or heart failure or malignancy. So this probably is not a representative of the real life picture. So in nutshell, cholecystostomy is indicated for 4Ds: drainage, decompression, diversion, and definite treatment of acute cholecystitis. Surgically placed cholecystostomy has advantages. You can place a wider tube, it's more efficient. It can decompress the thick pus and debris, and it can evacuate the stone at the same time without modern gadgets. It helps resolve acute inflammation, reduces mortality and risk of CVD injuries. And it's a great bailout procedure in high-risk surgical patients or those with acute cholecystitis or acute biliary obstruction, and is an alternative to endoscopic and percutaneous intervention. And it enables the definitive treatment in the form of interval lap chole, or is a definite treatment in some subset of patients. I thank you very much for that.
Thank you, Professor Farooq Afzal, for such a nice talk. The message is very clear that in gallbladder disease, if the person is suffering from acute cholecystitis and it's a category 3 patient, important thing is to drain it. Drain it either endoscopically through ERCP or through the endoscopic ultrasound, or with the help of interventional radiology, or through the rescue cholecystostomy. So these are 4 options that we have. There are always pros and cons to each and every technique. A surgeon will not like to operate on a patient who is acutely sick, who has got so many comorbid conditions. Anesthetists will not like to anesthetize a person, intubate a person who is extremely sick. And they'll prefer to have a relatively stable patient for the definitive procedure. And the definitive procedure remains the cholecystectomy, which is an end procedure. And end procedure means that unless we take out the gallbladder, the persistence of recurrent cholecystitis and persistent continuous making of the stones is going to stay there. House is open for discussion. There's a very interesting question from Afan, and he says that what is the role of spyglass cholangiopancreatography system in endoscopic transpapillary gallbladder drainage? Do you recommend spyglass for these procedures? Khalid, you're the most experienced one.
So the question is basically with regard to the spyglass for cystic duct drainage, right? That's the question. Did I get it right?
Yes, that's right. Yeah, that's right.
Okay. So spyglass, first thing is main goal is you're trying to get into the cystic duct itself. So if you can get the wire without the use of utilizing a $5,000 equipment, that would be much easier. And so you have to be cognizant of that. But rarely, it is very difficult to get the wire into the cystic duct. In those cases, yes, you can probably justify, but just to try to get the wire into the cystic duct, I wouldn't use that spyglass. Majority of the time using different techniques, different type of wires, cannula, which is much cheaper, I would utilize those to try to get into the cystic duct, and rarely a spyglass.
I agree, Dr. Khalid, because in intention to treat analysis of the recent study which has been published by Atoy in the Journal of Bones, it's very clear that we are able to get into the cystic duct in as many as 90% cases. It's just that we have to spend an extra time. Otherwise, the cheapest way to drain gallbladder remains the endoscopic gallbladder drainage. Amar, do you do tubogram? There's a question from Dr. Ali Naqvi.
Yes. So once we have placed a drain, I think in all places that I practice, I would schedule the patient for a basically what we would call a tube exchange procedure in, let's say, 1 month. And in that 1 month, the surgeon and the primary team has determined whether the patient is going to get a resection or not. And so if the patient doesn't get a resection, then they're scheduled for a diagnostic procedure. And during that diagnostic procedure, we're looking at the patency of the cystic duct. Sometimes the stone has passed. If it has not, if the duct is not patent, and if the patient's not a surgical candidate, then we start having a discussion with the gastroenterologist, the surgeon, and the primary care team about whether we should be removing these stones percutaneously or not. So yes, we are doing tubograms for all patients with the intent of, again, removing the drain as soon as possible. And I think that's really critical. Sometimes I think about 10 years ago, even at our center, the practice used to be that people were not concentrating on the cholangiogram or the tubogram, but they were just bringing the patient in and just repeatedly changing their drain with the thought process that there's nothing that can be done. And I don't think that's the best option. I think we should always be thinking about how to get this drain out.
There's a question to all the panelists. If a gallbladder has been drained by one technique or another, is there a point in going for a procedure like LAMS in a given patient who is otherwise surgically unfit?
So the question is, like it's been drained by one way or the other. So putting a self-expanding metal, like lumen opposing metal stent.
Yeah, lumen opposing metal stent. Yeah, that's right.
So one of the cases which I described, it's that patient who had a cholecystitis and had a cholecystostomy tube, but they didn't really, because of continued irritation. To some extent, there was a bile leak from the cholecystostomy tube. They were not happy with that and didn't want to go for a surgery either. In those cases, I would consider, and especially because of their age factor, other comorbidities, in those cases, I will consider LAMS so we can get rid of the external tube. So that would be one of the options. Other thing with regard to it happens is we're talking about what to do with those stones when you have a cholecystostomy tube. They don't want to go for surgery. Same thing we can do with the LAMS as well. Once you put that in, we have a good evidence now that there's a big enough stoma in there that we can put a scope through that too, remove the stone, and either leave that stent in. Stent has been patent for, have been shown to be patent for 2 years almost, and sometimes even when you take the stent out, it's just like a naturally having this like that stoma is epithelialized and it doesn't really close afterwards. So for those patients which are either not willing to undergo surgery or have so much comorbidities that there's not point of taking them to the surgery, in those cases, yes, I would consider a LAMS in such patients.
Nadeem, you want to say something? Can you unmute yourself?
Yes, Professor Riaz, thank you for the opportunity. Can I thank all these speakers and ask a question, maybe a comment? And I think it's maybe to Dr. Khalid Hassan and Amar Server. In your units, so what is the practice for? So I think there are two major situations. One is when the patient presents acutely with acute cholecystitis, as opposed to a situation when patient is presenting with recurrent cholecystitis. Clearly, I don't think many centers have out of hours endosonographers available who can come in and deploy the LAMS. And again, the expertise are mostly with the cholecystostomies IR guided. So the practice that I'm aware of in most units is that out of hours, they'll mostly go for the acute, the IR guided placement of the drain. And if the patient comes in within hours, then they can always consider the EUS guided report. But most EUS guided reports is restricted to patients who are presenting with recurrent cholecystitis. And that's one question. Second question, again, is to Dr. Khalid Hassan, is in terms of this, the choice of the stent that you're going to use for the gallbladder drainage, does it matter if you're using 6, 8, 10, 15, or 20? And if it's so, why? Thank you very much.
I can go with the, I think I can ask Amar can go with his thoughts later. So here is the deal with the EUS guided gallbladder drainage. You have to look at the expertise and you have to look at the resources available at your own institution. Percutaneous drainage of the gallbladder has been there for a long time and is much more universally available. And if you look at the EUS guided gallbladder drainage, I made it very practical, my presentation. But having said that, how many of those total cases have been done? You can probably, it's in hundreds, not even in thousands. And if you look at the cholecystostomy or IR guided, many more times than that. So even in our institute, especially after hours, we and majority of these ICU docs and majority of all these physicians taking care of such patients, they opt to call IR for cholecystostomy tube. And that happens in our institution majority of the time as well. Say with regard to the second question, that's really depends. If you look at my preference would be use the lamps we have available is either a 10 millimeter or 15 or 20. 20 I have not used for that. My option would be majority of the time 10 millimeter. The reason is like that you have to take a look at the size of this dumbbell of that lamps. If you put a bigger stent, there is either you're putting it into the duodenal bulb or very close to the pylorus. Bigger that dumbbell is, that more chances of food getting stuck in there or some debris getting stuck in there. There's going to be a mechanical obstruction with that. So my choice usually is almost always for this particular indication would be a 10 millimeter. Personally, that would be my choice.
I think Dr. Khalid has very rightly pointed out that the IR-mediated gallbladder interventions are there for many, many years, and EUS-guided drainage has just started recently. And we don't know the long-term results of these yet. But from Pakistani perspective, it's very important to understand that the EUS-guided biliary drainage is a very, very expensive procedure. Although we know that living is, again, an expense. But since the definitive procedure is surgery, EUS-guided biliary drainage may not be the right choice in the given patient. It is always good to go for something which is cheaper. Dr. Amar is here. Will please respond to the queries?
Yeah, I think all of you bring up excellent points, and that's kind of what I say. It's local expertise that depends. But you know, I mean, our center is quite a heavy EUS and ERCP center. They do a lot of interventions, and I have to say that with any new intervention, what we say here is that you're always going to break a few eggs before you start getting better at doing them. And you know, even with transduodenal procedures, we've seen malpositioned stents, spillage of the gallbladder, sometimes patient selection around patients with really tenuous gallbladder walls. If you're trying to kind of oppose the duodenum and like as something that's almost partially perforated or neurally perforated, I think it can be a challenge. And so I think, again, when it's bedside, I think, you know, patients on 2 pressors, really septic, they've come late, which may be a common situation in Pakistan. I think those type of patients, probably a PERC cholecystostomy is just the easiest way to decompress the patient and give everybody time to think about how to go for the intervention. I think from an IR perspective, what I would say is what we can do better and what this specialty could do better is to really manage the tube better and try to go towards drain-free survival. Because I think when you start to talk about that, stone removal, getting the patient drain-free, getting the gallbladder back to where it was, is quite possible without even putting an endoscope from a percutaneous approach. You can put like we use like a re-sterilizable bronchial forceps, and under fluoroscopy, you can just grab the stones and pick them out if they're radio-opaque. And so, but it really requires an interventional radiologist who's keyed into biliary procedures and is thinking about drain-free survival. And, you know, the thing that is new in IR is that we're starting to think more from the patient perspective and less from the procedure perspective. And I think, you know, that's the innovation that's happening in IR right now. Whereas in the past, it was just like put the tube in and then let everybody else figure out what they're going to do with the patient.
Perfect. If there's no more question, no more comment, it remains for me to thank all the participants, all the panelists, and similarly Wilson Pharmaceutical for providing us the platform for today's session. And see you next week. Have a very wonderful Sunday evening. Take care. Khuda Hafiz. Bye-bye.
Hafiz. Thank you.